Hi, this is Wesley Walker, former All-Pro wide receiver for the New York Jets. Stay tuned for Bridge to Health right here at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow. And for those of you who have seen our show in the past, you know what we're about. But for those of you who haven't, our show each week has a special guest from a different healthcare discipline to try to educate you, the audience, as to what each discipline's role is as part of our healthcare team. Very often you go to your doctors and you see one doctor, you see another doctor, then you see another specialist and another specialist. And those doctors never or seldomly communicate with one another about their treatment plan and their goals. Unlike our offices located in Melville, Hicksville, and Ronkonkoma, we have assembled a team of specialists, orthopedists, chiropractors, physical therapists, acupuncturists, pain management doctors, massage therapists, who work together under one roof as a team for you, the patient. This is very valuable because as each one of us determines a different problem is present, we then discuss it with the next discipline. And as a team, you, the patient, gets the a la carte treatment to give you the best chance of getting well. So this week, our special guests are Kenneth Radner, who's an orthotist and prosthetist. Welcome, Ken.
Thank you.
And we have Marty Diaz, who's an orthotist and a pedorthist. I think I said that right, close.
Correct.
Welcome, Marty. Thanks
Thank
for being on our show.
Thank you, Doctor.
So I'd like to start, I'd like you to explain to us, Marty, exactly what is an orthotist?
Well, an orthotist is a practitioner that gets a script from a doctor based on a diagnosis, and in its best way is to help the patient with the injury that may be surgical or non-surgical to stabilize that particular limb or device and get the patient back to a functional level.
Right. So, in other words, I think what you're trying to say, if I understand you correctly, is that let's say somebody has a knee injury.
Correct.
And they have surgery, or they don't have surgery, and that knee is unstable. Your job in your field is to pick and make or design, evaluate, and make the appropriate device that'll help that knee stay stable until it has time to heal.
Correct. And based on the doctor's input also that we were on the same team to make sure that the patient gets back to an everyday normal life.
Right, so the doctor will tell you maybe what special things he wants in that brace, right?
Correct.
Sometimes, right? Mm-hmm. And Ken, you're also an orthotist, correct?
Correct.
Okay, but you're also a prosthetist, correct?
Yes.
So what's the difference between an orthotist and a prosthetist?
Prosthetics mainly deals with the replacement of a missing body part. So if there's an amputation below the knee, an amputation of the foot, an amputation of the arm, the prosthetist would then evaluate the patient, mold them, fabricate the prosthesis, deliver the prosthesis to the patient, do some preliminary training with the patient to show them how to use the device, and then it would be the responsibility of the prosthetist and the patient to follow up with each other in order to maintain the device, determine if any further repairs are required, and in some cases determine when a new device is required. Because unlike your own living body tissue, these devices, they don't renew themselves, so they do wear out after time,
right,
and they often require repairs, adjustments, or replacements afterwards. So it's important to keep a good relationship with the prosthetist and the
So
patient.
the prosthetist deals with parts really that aren't there anymore.
Correct.
And that you're making a part to replace that part and
that's missing.
Try to give the patient the best function.
Exactly. You're trying to
that
return
they
them to
can
their
have.
functional level that they had previous to their loss.
And as far as making, changing things, I guess of course, when kids are young, you have to continually modify what they have as they grow, right?
Absolutely, absolutely. And it's very important when dealing with a pediatric case, with a child case, that the younger the child is, the more important it is to get that prosthesis on them as quickly as possible so they're able to incorporate that device into their body image.
Right.
If a child is allowed to proceed too long without a prosthetic device, children are very, very resourceful, and that child will find out a way to perform all their activities of daily living without a prosthetic device, and the prosthesis at that point may be seen as a hindrance. So it's really good to get the children started with it. It allows them to become much more functional and enhance their body image.
Gotcha. And Marty, now you're also a pedorthist, right?
Certified pedorist, yes.
Pedorist, okay. What is that?
Well, that's to deal with the foot problems, all the different issues that may have a problem with the foot, custom orthotics, custom shoes, off-the-shelf shoes, making sure the patient gets back to a normal gait, that their foot hits properly, because all the problems of the body, of the bones, start at the foot.
Right. Explain to us what an orthotic is, for the audience.
Well, for orthotic is orthotic is a replacement of the foot's problems that may or may not, have a recorrection.
Right.
So that we can put it into a shoe. We've actually either cast the patient or we have them put into an impression. We make it. It's made out of hard plastic, foam. It all different depends. And we add pads to it for adjustments, so that the patient can get back to having the foot put back into a neutral position.
So if a patient is having arch pain or heel pain,
correct,
and their doctor writes a script and says you need an orthotic for your shoes, that doctor would send that patient to you. You would then do an analysis and some type of exam, either with a casting or with a styrofoam mold they stepped into, to develop like an insert sole that goes into the shoe. And now when the patient walks on that shoe, their gait is normal. So you're basically, instead of treating the pain, you're correcting the reasons why their feet start to hurt in the first place.
Correct. You do a true evaluation, and you tend to manipulate the foot by hand to see how much correction you can get, because you don't want to cause something may be in a fixed position and create pain for the patient.
Many of my patients that come in with spinal problems, I found over the years it's due to foot problems, because their gait's not proper, one limb might be longer than the other, and many of my patients, I say, take your shoes off, let me say, oh, I got my own orthotic, I got it from the pharmacy, it was like $10, I'm not going to name the names of the products, but it was like $10, and my doctor says these are just as good as anything else. What's your feeling on that?
Well, I mean, we've seen patients come in with a bag of their self-treating orthotics that they've made themselves. So the proper way is to come into us, let us really evaluate you, and make that insert properly for your foot.
Right. The analogy I like to give to, you can't tell me if this is a good analogy that I give to my patients, is if you want to get a ski boot that fits you perfectly, what they do is they have you come into the store, they have you get into a mold, they take an impression of your foot, and the inserts that go in the foot actually mold to the exact shape of their foot so it fits them perfectly. Would that be a similar analogy, like for an orthotic, the difference between the ones you buy in the store and a custom one?
Yes, well, for a custom-made foot orthosis, the process is very similar to that. You are going to take a mold of the patient's foot through various processes, whether you use, they have a foam impression box, you could take a plaster cast.
Right.
But what that's going to serve to do is that's going to get an exact mold of the patient's foot, and any correction that you want to put in there, so that will help to have the patient achieve a more appropriate biomechanical gait.
Right.
And then the other issue is, which these prefabricated or off-the-shelf items don't address, is that you can have a patient who's experiencing very specific pressure areas. They can be experiencing metatarsal pain or pain under, under what people might call the ball of their foot. And these off-the-shelf items aren't really going to accommodate for this, but the orthotist or the pedorthist is going to look at the patient's foot, they're going to determine areas of increased pressure, areas of decreased pressure, and they're going to construct the device in order to accommodate and possibly even correct those conditions, if it's at all possible. So the custom device is far and away superior to the type of job that an off-the-shelf item can do.
I agree 100%. And I'll just share a story with you guys of several incidences I've had in my office where a off-the-shelf orthotic they bought in the pharmacy actually created major problems for them because it was not biomechanically designed properly to take into account everything else above their feet. Example is a patient comes in. Every patient that I examine, I always ask them, do you ever have any fractures, any fractured legs, any fractured ankles? Oh, yeah, I had one when I was about 7 years old. I broke my leg. As soon as a chiropractor hears that, red flags go up because now we have to look to see if the growth centers were affected, to see if the actual length from the top of the femur down to the floor on both sides is the same, or if the patient's got one leg that's shorter than the other, because that then is going to throw off the whole spine. So this patient comes in, and I ask him, back pain started maybe 6 months ago. Any trauma in your life to your back? Nope. Any car accidents? Nope. Any falls? Nope. It just came out of nowhere. I said, okay. Any broken bones? Any? Can you think of anything? Well, coincidentally, I had this heel problem, and I had a separated growth plate in my heel of my right foot, and my doctor told me just go to the store and buy a insert off the shelf and put it in your foot, and it'll be fine. This young kid, he's probably 25 years old, right? That's not that young, I guess, but and lo and behold, that was around the same time that his back pain started. So I then asked him, so you just put it in one side? He goes, yeah, you just said to put it in one side. Obviously, you just put it in one side. Now the whole pelvis gets messed up. The lower back shifts out of position. The vertebrae shift out of position. The nerves get pinched. It causes muscle spasm, causes pain. And lo and behold, I determined that that's probably what started his back. And when I took his x-rays, his spine, instead of being straight, was scoliotic because one side of his pelvis was higher than the other.
Right.
So I think I agree with you. It's very, very important that the right device is prescribed for the patient, taking not only into consideration the part that you're working on, but the other parts of the body too.
Correct. And just to add a little more with the custom orthotic, doc, is that the proper footwear. So you can have the right orthotic, and because of the weight that you are or your other issues that are creating your gait to be off balance, as we evaluate your gait, we're also making accommodations to the shoe wear, where a wedge may force you back into a better position. You know, your toe off may not be there, so we put a rocker bottom or a heel lift.
Right, right.
So so the foot orthotic, you're correct, are crucial, but also it must work into the proper footwear. And most people don't wear the proper footwear.
I love the people that come in with the orthotics, the real ones that you guys make, and they're wearing sandals, or especially women with high heels this high. And I'm like, that's not going to work, as they're saying, because they don't have the proper footwear to support the orthotic.
Correct.
Exactly.
Right?
Correct.
And then if I may add to that too, one thing that's extremely important about going to a professional that trains and is used to dealing with these items is, for example, you go to the pharmacy and you buy these off-the-shelf items and then something's not functioning properly or there's some kind of issue with them. Well, you basically just went and bought that device yourself and almost prescribed and diagnosed that item on your own. You're now on your own.
Right.
If you have a device that's custom fabricated by a pet orthotist or an orthotist and there's some kind of question or some kind of confusion or some kind of issue with it, you take it back to that practitioner, and they can then modify the device, adjust the device, or change it, and achieve the goals that the patient's looking for, which is something you will definitely not get if you decide to just grab something over the counter from a pharmacy.
And to add to that, Ken, is that when you recorrect the foot, you may have had the problem for so long that it may be creating pain in some other areas of the body.
I've seen that.
And we have to inform you ahead of time, being a professionals, that you may occur this problem, and the next thing the patient says, you know what, you're right now that, and so we have to make another adjustment to correct that, hopefully a little bit more.
And sometimes you might have too much of a correction. You got to back it off.
Well, that's what I'm trying to say.
Until the body adapts, right?
Exactly right. Exactly right.
It's going to be anywhere from at least 2 to 4 visits to do it properly.
So I have an interesting question for both of you. One of my biggest challenges, or our office's biggest challenges, are women who are pregnant. As they get later and later into their terms, their spine starts to go back more. The lordotic curve increases because of the extra weight they're carrying, and they develop lower back pain. Is there any type of orthotic that can shift and compensate that tilt due to that pregnancy, or is that not something that's been devised yet? See, I gave you a good idea.
No,
Well, they do have the pregnancy supports.
So, well, we have the pregnancy
they're
supports.
soft items.
And
No,
soft
but
goods.
that's here.
Yeah, you're talking about for the feet.
I'm talking about here. Think
Yeah.
about it. When that woman's pelvis is shifting and that whole
But
body
she's
when it's
shifting
going
forward.
forward,
Right.
maybe something can be devised for the
Well,
feet
you're
that'll
actually
help
trying
her
to
go back.
But you're trying to.
You want to bring her back, and then, well, the other issue going along with that is, obviously,
Where's-
a rapid increase of weight, you're going to put more stress onto the medial longitudinal arches, so you're going
Right.
to need support there as well.
Right, exactly.
And then, I mean, as far as shifting things back, you can definitely biomechanically look to shift the foot orthotics, whether it be building up under the toe to try and shift everything
Yeah.
back, dorsiflex the feet, and get the patient to
Right.
sit back a little bit more.
Right.
That can be adjusted in order to achieve an optimal alignment, and that's really what's great about coming back and forth into the actual office of the orthotist.
You can
They-
keep modifying.
They'll
and
put a little
adapting
device
it.
in. How does that feel? And then send them back to you. So it can be an ongoing adjustment until the patient achieves the biomechanical goal they're looking for.
Right.
Correct. And if you got to be careful with that, because the pregnant woman may have an off-balance situation created by the shoe. So the best may be just to support it this time and
Right.
check with the doctors and put a minimal amount of support in there, because
Right.
that's an area
Yeah, just
you don't.
it's a question that came
Yeah,
to
it's a
my
tough
head.
area because some
That's all.
carry small, some carry extremely large.
Up high, out.
And you do orthotics for shoes for children too, pediatric
Yes.
orthotics? And I've heard different opinions from different practitioners. Hard orthotics are better. The softer ones are better that have shock absorption built into them, the sorbethane or whatever they use for that. I've heard that casting is better from podiatrists. I hear chiropractors saying weight-bearing castings are better. What is really better, or is each one, it depends on the condition?
They each serve their own purposes. In many cases, it depends on what's trying to be achieved. So if we're looking for a maximum amount of correction on a patient, a non-weight bearing cast would probably be the best way to achieve a shape. Being that the patient is non-weight bearing, you're not depressing the arch, so you're going to get the greatest amount of correction that you could possibly get, because
Okay.
gravity's not pulling the whole foot out of shape. So by casting them in a non-weight bearing position, you're going to get that maximum amount of correction.
I don't want to say deformity, but the true bad biomechanical structure.
Right, and that can
You
be
correct.
Yeah, and then that can be corrected. So in other words, the patient is non-weight bearing, and then you notice that they have a varus or valgus forefoot. You can then, in that casting,
Right.
correct the patient while you're non-weight bearing. So again, we're getting our maximal arch support, but you're also providing some biomechanical correction. And then even later on in the process, when the actual cast is being used to make the foot orthotic, the cast itself can be modified.
Right.
There are many different cases. The foam boxes that they tend to dip people into, many times those are called semi-weight bearing castings, because the
Okay.
patient is not entirely bearing all their weight down upon it.
Right.
So you do get some arch support,
Right.
but you are applying a little bit of weight to the patient in order for them to sink in the box, so you're not getting your maximal amount of correction.
Right.
That's sometimes better for adults, because if you tend to correct an adult too much, it results in pain. A child is more flexible, so you're looking for more major corrections with a child than you would with an adult.
But I would add to most all of the type of bracing we do for the peds are custom molded.
Okay. Let's get into now your orthoses
Okay.
and the devices that support joints that have either been surgically operated on or are unstable. Could you show us what an elbow brace looks like?
So right here, this is a post-operative type of elbow orthosis. It is created in order to limit range of motion or eliminate range of motion in order to reduce motion to the joint in order to allow for healing. So in this part, you can see we have our device locked up here. If we unlock it, we can achieve a full range of motion. And then if we actually set our limiters here, we can limit our range of motion as is seen fit. So these can be used in various diagnoses. You can use these post-surgically. They can be used after fractures. They can be used after ligament tears. I've seen some patients who they get when they hold their arm up at night and their arms go to sleep. It's something called ulnar neuropathy. You can use this device to keep their arm extended. so that they don't experience that neuropathy. So it really is a nice sort of catch-all, almost a panacea. It provides a great amount of treatments for various different diagnoses, and they're great. You can use them directly traumatically, or they can be used chronically.
And your knee one is similar, correct? With the,
Yes.
with the range limiters?
This is a knee orthosis that is basically a partner to this one. It serves the same purpose. It has the same lock up here that performs the same range of motion adjustments. And this, again, can be used post-surgically, post-traumatically, after the patient has an injury. If the patient has had, some kind of ACL, partial tear, they need to be in this for a while to let everything heal up. These tend to be used more in the acute phase of treatment. Later on, the patient then moves, if they develop a chronic condition due to their injury, they can then move to a supportive device that is used post-operatively or
And
in
what's
a
great
chronic
about
situation.
these from our standpoint as doctors is we can specifically tell you, I only want that leg to flex 30 degrees for the first week. After the second week, I want it increased to 40 degrees.
And true, and this post-operative brace is used for when you go to see the doc and they need an MRI and you want to stabilize that condition. There may be other health reasons the patient can't get into surgery right away.
Right.
So the surest way to try to stabilize that patient until you find out exactly or when they can go in for surgery.
Can you show us your low back support?
Sure.
Somebody comes into our office, they have acute low back pain, they can barely move. This is a custom, correct?
No, this is a prefabricated.
Prefabricated back support,
Yes.
which gives the patient just general support so they, number one, they're in less pain and they can limit their motions, right?
Exactly.
Right.
So this device, you can see we have, this is our back, this is our posterior section of the back section. We have the front, both of them have a rigid plastic shell in them. That is meant to provide compression as well as direct mechanical support. So the device is closed on the patient and then it's cinched up tight. And basically we want these devices to be tight on the patient, and that's usually the first complaint most patients are going to have when going into one of these is oh, it's so tight. The issue is we need these devices to be tight because not only do they provide a physical limitation of the range of motion, they also provide a thing called intracavitary pressure, which works off of hydrostatic tension or hydrostatic pressure. In other words, the human body is greatly composed out of water, very analogous to a tube of toothpaste. That's the analogy I like to use. So when you take a tube of toothpaste and you squeeze it at the top and bottom, the things tend to squirt out the top and bottom. The same happens here. So you squeeze in the middle, it distracts the spine and it reduces the chance of the vertebrae to crush down on each other.
Right.
So it reduces pain and it would reduce any kind of compression on a nerve.
Just another thing, when we use off the shelf, we really, as practitioners in orthotics and prosthetics, we want to make sure that we're following the doctor's prescription.
Right.
Even though the doctor is right, it's our evaluation to see if this device is going to help that patient or hurt that patient.
Can you show us the custom back brace right now?
Absolutely. All right, so this is our custom fabricated one. Now, this device can be made either from a casting or from measurement. When you measurement, it's something like 30 or so measurements that we take to make this device, to fabricate this device, or it can be made from a cast.
Right. Now, Ken, this is for patients who have had surgery or they've had fractures.
Yes.
And you don't want any movement there.
Exactly.
Right?
This is really for your more acute cases.
Right.
When you're really looking for some of your maximum amount of stabilization, this is what you're going to go into because it's specifically shaped for the patient. It's going to fit them, and it can be adjusted to be either tighter or looser in order to provide the maximum amount of support the patient would need to heal.
Gotcha.
Limited rotation and everything.
Gotcha. And you also, as part of your practice, again, getting into prosthetic devices, make devices for people who have lost limbs. Could you show us an example of one of those?
Absolutely. So at our most basic, this would be a prosthesis for a patient who has experienced an amputation below their knee, what we would call a transtibial amputation, so through the shin bone, through the tibia. What these devices seek to do is they seek to take weight-bearing forces that would otherwise be applied to the direct bottom of the patient's residual limb, or what's commonly known as a stump, which cannot bear weight because of the bony anatomy, and transfer it to areas on the patient's residual limb that can take weight bearing without having any kind of skin breakdown. So it helps to transfer the biomechanics to another area while allowing the patient to become functional, allow them to become weight bearing, and it returns their function to them through uses of various materials.
And again, I would imagine something like this, especially when you first put it on them, there's an adaptation period where they have to get used to
Absolutely.
it. They have to keep coming back to you to make sure it's fitting them right. They're not getting any ulcerations in the
Correct.
stub. Crucially important that the patient follows up with you in these cases.
Right.
Absolutely.
In most cases, when a patient loses a limb, immediately we try to get what's called an IPOP system, similar to this,
Right.
so that they feel proprioceptionally that they're still a whole person,
Right.
so that the limb is not missing, and so that we can help and have a better outcome in rehab and adjustments with the prosthesis.
So there are many, many different devices. You probably have orthoses and prostheses for all parts of the body, right?
All
You have it for hands and arms and
fingers,
everything. So the bottom line is that your job, which is an admirable and awesome field, is to try to get our patients back, whether they lose a limb or don't lose a limb, back to as normal function as they can with their injuries or with their disabilities, so they can carry on a normal lifestyle.
Right. I mean, just to
Not
give it
as best as normal. Yeah.
Well, our job also in working with the doctors, we have a lot of devices that when a patient has a wound or an ulcer happening in a certain area, we're trying to de-weight that body to save that limb.
Right.
And so our devices are used, and then of course at the end it's up to the patient if he's healing properly or not, and up to the doctor to decide.
And Marty, where are your offices located? Where do you work?
We have offices in East Meadow, Long Island, Nassau County.
Right.
We have them in Queens, Flushing. We have 2 in the Bronx,
Right.
and 2 in Manhattan, and 1 in Brooklyn.
Right. And name of your company is?
Complete Orthopedic Services.
Nice. Do you have a website in case people
Yes.
want more information
It's
on these different devices?
Yes, www.completeorthopedics.com.
Great. And is there a phone number they can call you and speak
Sure.
to you if they have any
516
questions after the show?
Absolutely. They can ask us any questions based on insurance, services, or
Oh,
whatever.
that's another thing that I didn't bring up, that a lot of these things are covered by insurance, right?
Yes, and we will work with the patient to make sure that if we don't, where we can get it for them.
Gotcha.
So we just don't hang up the phone. We give them the best service. So call us anytime for any question.
And what was that number again?
516-357-9113.
Nice. Gentlemen, I'd like to thank you very much for being on my show today. It was very educational for me, and I'm sure for the audience. Thank you very much.
Thank you.
Thank you, doctor.
For those of you watching us on Madhousetv, stay tuned. We'll be right back. For those of you watching us on Public Access Cablevision Channel 20, we'll see you next time. And remember one thing, if what you're looking for is real wealth, join us next time on The Bridge to Health. If you're watching us on Madhousetv, stand by. We'll be right back. If you're watching us on Cablevision, we'll see you next time.
Thanks for watching.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
You're watching MadhouseTV.com.
Hi, I'm Wesley Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at MadhouseTV.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name's Dr. Tom Dow. And each week we have a special guest on our show, which is part of our healthcare team to help you, the patient. Our offices in Melville, Ronkonkoma, and Hicksville are much different than most offices. In our offices, we have a team of professionals who work hand in hand on a daily basis to give you, the patient, the best care possible, kind of like a la carte. And if we don't have professionals in our offices that we need, we have a network of professionals we can just get on the phone with, speak to, and they can help us solve the problems of diagnosis and accurate, really good treatment. Today, we have a special guest, Dr. Salvatore Corso. Hi, Dr. Corso.
How are you?
Thank you
Pleasure
for joining us today. Dr. Corso, by trade, you are an orthopedic surgeon, correct?
That's correct.
Okay, and you are now getting into kind of like the pain management realm at this point now, with what's been in the headlines all over the nation, medical marijuana, correct?
That's correct.
Okay, so let's talk a little bit about medical marijuana. Let's kind of like get rid of the myths and dispel some of the untruths about what medical marijuana is and what it isn't. So, when did you first find interest in medical marijuana as a treatment option to help your patients who have chronic pain?
Well, first of all, Tom, I do have a significant number of patients that suffer from chronic pain. It could be from arthritis, it can be from any type of neurologic issue, and it's a very common issue in my practice. I've had situations where I usually have to prescribe, even post-surgery, patients opioid-type treatment, including narcotics, Vicodin, OxyContin, oxycodone, and as you know, which you see in the paper quite often, it becomes a real issue, certainly from an addiction standpoint and certainly from a side effect standpoint with having to treat patients over a period of time. And certainly I do have chronic patients that I see with these problems. I did have the well-being of being associated with a physician who happens to be also a family friend who's a GI doctor at North Shore Hospital, who got involved with one of the groups that was trying to obtain a licensure for distributing medical marijuana coming up. And as we know, January 1st of 2016 is when it will become legalized in New York. He asked me to be on the medical board of this particular company. As it turned out, this particular company did not get one of the licenses, although they are going to continue, I believe, to pursue that. But at the same time, the concern that we had was that there really is not a lot of research. Why? Because, as you had said, some of the myths, medical marijuana back in 1960, due to one of the acts of Congress, was considered a Schedule I drug and became illegal, mostly because of the recreational standpoint. And I want to make sure that I emphasize the fact that we're not here to advocate in any way the use of recreational marijuana. This is strictly through a medical use of the drug.
Right.
And as we're finding out with the amount of research, even though it's been limited because it's a Schedule I classification, and the any type of monetary use of it towards research and developing the types of regimens that should be used has been limited. So studies have been, and this is why it has become a myth. What we have found out is that there are over 60 types of chemicals within the marijuana plant, a lot of which ones that do not cause any psychotropic or high effects as what might be seen. And we've even seen it be effective in children when there is a higher dose of the CBD, and we'll talk about that, content of the plant. And therefore, it's a very safe treatment, again, with more and more research.
Okay. So let's go back to myths, okay? When I grew up back in the 70s, my parents thought of marijuana users as killers, psychopaths, psychotic people whose minds aren't quite right. Whereas today, medical marijuana, they don't smoke medical marijuana, correct?
That's correct. There are patients that do. And that gets us to one of the real keys to the route of administration or the delivery system that's used.
So there will be medical marijuana smokable in New York or not?
I believe that it will be allowed to be smoked, but really the focus is going to be more on either the edible type or what's considered now much safer as far as inhalation. Inhalation is one of the ways, the traditional ways to smoke it. However, with that, there is some concerns. Concerns about its effect on the lungs, concerned about the carcinogens that are smoked with it.
Right.
There is now found to be what's called vaporization, or as you see on with e-cigarettes,
Right.
where the plant material is actually burned and vaporized without burning the carcinogenic type materials, including the benzenes, the carbon monoxide, and the tars that are found in the rest of the plant. So what is done is the vaporization works not only to minimize any effect or risk on the lung, and certainly any risk of cancer, although again that has not been associated with studies with regular marijuana smoking.
Right.
But not only the vaporization, what it brings out is the terpenes, which is another material or chemical within the plant, which has been shown to have an anti-inflammatory effect.
Really?
So it works not only to protect the lung from risks, but also protect the lung from inflammation.
Right. Okay, so we all know how dangerous opioids are now and how they're abused. Not by everyone, but certain people abuse them. Then they become hooked on them. Then the next thing they know, they're doing other recreational drugs. Is this medical marijuana addictive?
There is certainly an addiction, or I want to say a dependency. But here's the difference. First of all, it is, as far as a side effect, one of the biggest things is there are no receptors, cannabinoid receptors. And one of our other guests will get into the endocannabinoid system, which is found in the human body. But there are no receptors in the brainstem, which controls respiration, as opposed to an opioid. So you can overdose and die from an opioid, from a respiratory seizure, or basically stopping breathing. It does not occur with medical marijuana. So really one of the biggest and most dangerous side effects really is not in play as far as that concern.
So death and overdosing from respiratory arrest doesn't happen with medical marijuana?
Does not happen with that. Can occur, obviously, with opioid treatment.
Okay. So if somebody, once this all becomes legal and you as a doctor or other doctors start to prescribe this drug, which is going to help people with their chronic pain, can they drive when they're taking it? Does it affect their reflexes? Should they only take it at home when they're going to bed? Because I know certain narcotic medications, they recommend you don't operate machinery or drive because of how it affects your reflexes and things. Is this the same?
There's no doubt, as far as depending on the content, again, when we talk about extraction of the material from the plant, and we can get into that whole factor, but as far as if you're using a plant or a dosage that has a higher CBD content, there's two main ingredients that come out of the plant that are therapeutic. One is the THC. That has a psychotropic effect. In other words, it affects or connects to receptors in the brain, so it will affect certain things like coordination. It may increase your heart rate.
They give you the munchies too, right?
It can definitely do that. It can cause dizziness. But the truth is that there are a lot of treatments where the CBD aspect, which does not have any psychotropic effects, it does not make you high, but yet it is very effective in anti-inflammation, in treating muscle spasm, in treating spasticity in multiple sclerosis. So there are patients that have that regimen or that dosage.
And they're not going to get high. They'll be able to carry on life as normal.
They can take it during the day. They can work very well and do whatever they have to do. However, certainly any type of medication that has THC in it, you're going to have the same precautions as you would with a narcotic. You should not drive. You should not operate any heavy machinery. And there are some other precautions which we can talk about.
I saw an amazing documentary or video presentation. It was about a year ago, of a little girl who suffered from terrible seizures. She'd be walking along and all of a sudden, boom, she'd fall down. It would happen like 10, 15 times a day. And they gave this girl medical marijuana, and it's like stopped her seizures. Is that what happens in real life?
Well, this is what's called Charlotte's Web, or this was named after a girl named Charlotte Figge, who's basically now about 9 years old. When she was 5, they were able, there was actually a Canadian named Simpson who was able to extract the oil from the plant, high CBD content, so there was no getting high from it. And he supposedly states that he was able to cure a skin cancer. The same type of extraction was given to this girl, Charlotte, who was having multiple daily seizures from a disease called Dravet syndrome. And she took 1 dose, and it reduced the number of childhood seizures. There was another girl, another one called Haley's Hope. Okay, this was, again, a mother who could not get treatment for medical marijuana. Her daughter was having up to 200 seizures a day, which I can only imagine the stress and the anxiety and what it was causing the family and the child as well. She moved to Colorado, started medical marijuana treatment with an oil with high CBD content, and she was able to get the seizures down. On a bad day now, she has 7 seizures. But most of the time, it's minimized to just a couple a day.
Wow, that is truly, truly incredible. And what a life changer that is for that family, huh?
Absolutely incredible. And that's where I think the focus going forward is going to be on this type of, especially for those types of situations. Childhood, where you have situations like this, where you can actually, in some cases, it's even been described as healing childhood cancer, certain types of cancers, that it is effective in slowing down the genetics of the particular cells that are causing the cancer in the person.
So you stated this also helps like muscle spasm and muscle spasticity. Is that true?
That's correct. As a matter of fact, there's now prescribed medication. There's something called Sesamet, which the generic name is Nabilone. Okay, it is a synthetically made marijuana. It is THC. That is specifically used for patients that have cancer, that are on a strict chemo regimen, and that have adverse side effects, including nausea, vomiting, loss of weight. Those patients are given anywhere from 1 to 2 milligrams prior, maybe 1 to 2 or 3 hours before chemo treatment, and it completely controls those side effects of the chemo. There is also what's called the Sativex, which is an oral mucosal spray. So it's only one spray. It can be given up to 12 times in a day as far as a dose, and it has been shown to be very effective against muscle spasticity in patients with multiple sclerosis, which is...
that was going to be my next question. For MS or any spastic diseases, has it been shown to help?
Tremendous. As well as, again, in chemo, patients with anorexia, losing weight. Obviously, it does affect the appetite in that way.
Wow.
There is something called dronabinol, okay, or Marinol, which is, the brand name, which is given to patients on a regular basis that are on chronic chemo, and it does, abate the side effects.
That is awesome. Now, on past shows, we've had other physicians here. We've talked about nutrition. We've talked about purity. We've talked about pharmaceutical grade nutrient products to make sure what's in it is in it. Let's talk now about how they get this medical marijuana oil or vapor. Is it derived from plants? Is it made in the lab? How pure is it? How do we obtain that?
Well, it's funny because the extraction process is relatively simple. Nowadays, they have these, huge machines which are called botanical oil extractors. You can put anywhere from 25 to 50 pounds of the plant material in it. It may produce 5 gallons of oil, and it's done without using any solvents, which can be used on a simple basis if you use a solvent to draw the oil out of the plant. But it's just simply taking the plant, drying it out, compressing it, grinding it up, and then using a solvent and an evaporation process to obtain the oil. And I think, again, the oils and the waxes are going to be the materials that are really going to become very effective and are going to have the least side effects because, again, you're not going to have to inhale it.
Now, when you say oil, is that what they make the pills out of, the inside of the pills?
That's correct.
So there's oil inside the pills.
That's correct. They'll make capsules out of those. They'll also have topical oils and, again, waxes or certain materials that can be put into baked goods so that you can eat it.
Interesting. Let's talk now a little bit about dosing. You're a physician. You've got a patient with, on a scale of 0 to 10, 0 being no pain, 10 being the most severe. He's got an 8-level low back pain. It's been there for years. He's had 5 surgeries already. This is chronic. It's not getting any better. How do you, as a physician, know how to dose that patient? How much should he need?
There are some standard general principles that we may use, but here's the difficulty is that, of course, this is an atypical medical model. Why? Because it may depend on a lot of different variables. It may depend on the receptor structure, the number of receptors in a particular person's body, which would affect the metabolism of the particular cannabinoid that might be given to that patient. It may also be a factor of whether they had a prior exposure to the medication. The plant material, how strong is it? What type of strain is it? Again, when we get back to the research, when I've looked up and gone through my own literature search and read specific articles, there's no real standardization of treatment, okay? But there are some general principles. If you look at some of the professors, there's a gentleman named Don Abrams. He's a clinical professor of medicine at the University of California. He's done a lot of work and has treated patients with that have used medical marijuana. In going back to the traditional way, smoking, he talks about it pretty much being something where a patient who's a frequent user would be able to titrate or regulate his own dose, but always start with a small dose. So maybe they talk about using 1 puff at night and then taking anywhere up to the Health Canada speaks about anywhere from 1 to 5 grams as a maximum of a day. That may be up to 7 or 8, maybe 10 cigarettes if you're talking about that. If you're talking about the dosing from the pharmaceutical products that we have now, it's 1 to 5 milligrams per kilogram per day for a particular individual. So there are, depending on the weight of the individual, and again, if you're talking about chronic pain, you're going to want a ratio of THC to cannabinoid of 1 to 1. So it is going to be something where that particular patient, you're going to have to give them the warnings. They may get a so-called high from it. They're going to have to take the precautions of no driving, and operating heavy machinery, things like that.
With opioid drugs, pain management doctors, traditionally they'll do urine tests on the patients to make sure that they are using the drugs that they're prescribing and they're not selling them somewhere else. Is that going to happen with this medical marijuana? Is it going to be urine testing to monitor the same way as if they're using it and they're producing it in the urine?
There's no doubt. The tetrahydrocannabinol, there are byproducts as well as the CBD that are found in the urine. It's easily cleared by the body, and that can certainly be monitored, and I think it will definitively be required by the New York State Department of Health as far as following up. Not only that, and that gets into our next venture, which is what in getting into this, we're really into the academic side of it. There's no doubt that physicians that will be looking to prescribe medical marijuana will, I believe it's already in law, that they will be required to take a CME course, specific number of hours, that will go over the entirety of the treatment of medical marijuana, certain protocols, the research that's been based. And we, as myself, Dr. Weisberg, who will be a guest as well, future guest, as well as Dr. Larry Good, we have formed what we believe is going to be a company that's going to get accreditation so that we can educate doctors about the treatment. And at the same time, we may have the ability to have algorithms at our hands, at our disposal, that will give us feedback. Excellent. And therefore may be able to look into some more research and be able to then forward that to the doctors that will be treating patients.
Interesting. I'd like to make it very clear to you in the audience that the whole purpose of our show, of the Bridge to Health, is to bring a team of professionals together to try to solve your healthcare problems as a team, give you the best treatment each profession has to offer to try to get you healthy. However, there are those class of patients that we've tried everything with. They've had surgeries. They have chronic pain. And these people have to have some quality of life. This treatment of medical marijuana, I feel, is probably going to be much more beneficial than the opioids we're currently using, which we already know what the effects and the addictive abilities of those are. But understand that health also involves life quality. If you're in chronic pain all day long and you can't go out and you can't enjoy your family, you can't enjoy your kids, there's no quality of life. You become depressed, you become anxious, your whole mental state dives. And if your mental state dives, your physical state follows. So understand, this is something which isn't for every patient. It's for those who have a quality of life and there's nothing really else to do. Is that pretty much true? You agree?
There's no doubt. As a matter of fact, there are a prerequisite list of disease states that are treated and that can be used for this particular medical treatment. So it's not going to be anyone that just feels like they want to go in and get some marijuana from a doctor. There will be questionnaires that have to be filled out. There are specific protocols that have to be followed, which you just touched on, which is going to be urine testing. There's going to be follow-up. And I believe that as far as, the dosaging, it's going to really be something that's restricted and followed on a very close basis as far as going forward with disease states. But there are, if you look into the literature, there is a widespread application of this medication to various treatments, again, including childhood epilepsy, childhood cancer, certainly Alzheimer's disease, HIV, cancer, multiple sclerosis. It decreases pressure in patients with glaucoma. There are just a litany of disease states. And again, probably not even the ones that will be allowed by New York State, at least in the initial phases. But again, this is a learning process. And this is something that will continue to evolve over time.
So besides the anti-inflammatory effect, the pain control effect, and the munchies, are there any other side effects from medical marijuana?
There are side effects. They're found to be very mild. There are side effects. You do get tachycardia. You can get dizziness. It does have a an effect on short-term memory, and it can also have effect on muscle coordination. And withdrawal symptoms from it are things like anxiety, shakiness, again, increased heart rate. You might have nightmares, you might have headaches. But these symptoms are usually within 1 to 2 days. They may maximize in anywhere from 2 to 5 or 6 days, and they may be gone within a week.
Any contraindications? Are there patients that you say you can't take medical marijuana?
Well, it's interesting because there really are from what I could see in the literature, there are no definitive contraindications. However, certainly anything with a high THC content is not seen to be beneficial in people under the age of 18. One of the biggest, although again, as we talked about, the high CBD to THC ratio is extremely effective in childhood epilepsy. It is not recommended in pregnant women or breastfeeding women. Why? It readily crosses the placenta. It accumulates in breast milk. So it's been shown in these particular individuals. There's been some research that has shown that it will cause an increased risk of cancer in some of those children, low birth weight, possibly even an increase in leukemia.
What if they're taking other medications? Any kind of contraindications or side effects with other meds?
There are some things that have to be looked out for, certainly in patients that are taking opioids. It has been beneficial in lowering the amount of opioid that patient takes. So that's what's good about it, because why? It potentiates the effect. But if the dosages aren't worked out correctly, some of the patients that they've looked into have shown that there's a significant increase in the high and the duration of the high. It's not something, you can get a side effect as far as the lungs. So anyone with any type of respiratory disease, it can cause some chronic bronchitis. So anyone that has any type of cardiovascular disease, because it can increase the heart rate and lower the blood pressure in the acute phase, it's something to be concerned about. And also any patients that may have a familiar history of some type of depression, schizophrenia, or even mania, it may bring out those symptoms in patients that really don't have those disease.
Thank you very much. Could you let the audience know how to contact you at your office or an email address if they have any questions?
Sure. My office is in Woodbury. It's at 205 Frolic Farm Boulevard in Woodbury, New York. The office number is 516-364-0070. Call and leave a message. I'll be more than happy to get back to you. Again, not only for the possibility of treatment of medical cannabis in the future, but also for any type of orthopedic issues that you may have.
Dr. Corso, I want to thank you very much for joining us, and we will have you back again at a future date. For those of you watching us on Madhouse TV, stay tuned. We'll be right back. For those of you who are watching us on Cablevision Channel 20, remember one thing. If what you want is real wealth, join us next time on The Bridge to Health. If you're watching us on Madhouse TV, stand by. We'll be right back. If you're watching us on Cablevision, we'll see you next time.
Thanks for watching.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.